The House Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Beerline.
Here.
Representatives Paquette. I'm here. Green.
Present.
McDonald.
Present.
Cerniglu.
Here.
Mr. Chair, you have a quorum.
Representative Cerniglu moves to approve the minutes of the June 3rd meeting. Hearing no objection, they are approved. Today, we're going to continue the discussion on the psychiatric bed shortage in Michigan. And first, we're going to start with Steve Vernon, CEO of Cedar Creek Hospital in St. John's. And joining him is Jamie White, CEO of Havenwick Hospital in Auburn Hills. Thank you both for being here. Please take the seat and just push the red button to make the microphone come on.
Thank you for having us. This should be pretty brief, and so we'll leave some time for questions at the end. We are here representing Universal Health Services, which is the largest behavioral health company in the country. And under that is 5 freestanding behavioral health facilities here in Michigan that we represent. So Cedar Creek Hospital, which is my hospital in St. John's, Jamie's, which is Havenwick Hospital, the largest facility in Michigan down in Auburn Hills. And now we have not Beaumont anymore, it's Metropolitan Behavioral Health in Dearborn. We have Forest View in Grand Rapids, and then a newly opened facility in, not Comstock Park, in Byron Center that just opened actually a week ago today called Southridge Behavioral Health. So we have a large footprint in Michigan and are seeing some of the same struggles that you guys are seeing within this committee that we hope to answer some questions for on who we're seeing and not seeing within our facilities. Any questions on who we are or who we represent? So we have, as we continue to find ways to meet community need and community demands and work with our referral sources within our communities, UHS facilities here in Michigan, we have a ton of expansion projects underway or planned for the very near future. And you'll see them here on the slide. So as I mentioned earlier, Southridge Behavioral Health just opened their doors last week and is a 96-bed facility. My facility in St. John's, we're getting ready to open another 16 beds. I'm going to be breaking ground in the next month or so. And then there is plans by the end of this year, by the end of 2025, where we will start construction on a 48-bed facility here in Lansing. That'll be 24 kids and 24 adult beds. Havenwick Hospital, Jamie's facility, is in the planning stage. It sounds like maybe over a 3-year plan to add 52 additional beds to the 200 and some that they already have. And then we do more than just inpatient within our company, so we also have some outpatient facilities spread throughout the state. So we have kind of facilities with a substance abuse facility called Skywood. So we have one in Grand Rapids, one in Auburn Hills, and one in Lansing. And so we're offering some pretty intensive outpatient services 5 days a week as well.
So as Steve mentioned, we are 100% investing in our communities. We are constantly looking for ways to expand and meet the need. Those, of course, are longer-term plans when you talk about building new hospitals and putting additional beds online. Our investment in intensive outpatient services is also meant to really meet that need for individuals who may be requiring a step down from inpatient care or can actually avoid inpatient care by having a lower level of care provided for them in the community. We do have a couple of suggested solutions that we would like the committee to consider. One of them really has to do with the way our bed licensure works in the state of Michigan through the Certificate of Need process. So currently, we have the ability to apply for flex beds. Those flex beds can be flexed from adult beds to child and adolescent beds, but it does not allow us to flex from child and adolescent beds to adult beds. And so that really limits our ability as operators of the facility to flex to meet the needs of the community. So as you will see from the data on the bottom of the slide, we defer thousands of adult referrals every year, very heavily during the summer months and over winter break. So during those times, the need for child and adolescent beds for an acute inpatient psychiatric bed really fluctuates. And we will have our child and adolescent units at usually less than 50% capacity all summer long, while our adult beds remain full. We have served on subcommittees within CON. We've talked about this issue. Unfortunately, we've been unsuccessful in making any change. But in our mind, that is really kind of a short-term solution, low-hanging fruit, if you will, to really open up access for more adults pretty quickly. And the other thing that we really wanted to talk about today is really looking at some longer-term solutions. So we feel really strongly that in continuing to invest in the PRTF beds, the psychiatric residential treatment facilities, will allow for the right beds at the right time, especially for our child and adolescents. Many of the referrals that we see are children that have had multiple short-term acute inpatient stays and are really in need of a longer-term residential program or even a state hospital bed. And we find that our facilities, being set up for a 7 to 10 day stay, are really not equipped for that level of need for those children. What we do find, and we've had a few specific instances, specifically at Havenwick, is that, when we kind of really flex to meet that need, we bring the child in with additional supports, we work it out with the referring county. Sometimes those children are with us for months and months and months, waiting for a state hospital bed or waiting for another appropriate placement. So we really feel that continuing to invest in those programs, making them accessible to all of our communities would really help with this shortage. We also have to consider our reimbursement levels, and so hospitals are reimbursed at the same rate by payer. There may be some slight variations based on if the child or the adult needs a one-on-one staff, but generally speaking, we receive the same rate across the board regardless of acuity level of the patients that we accept. And we are really asking the state to continue to collect data on what the specific type of need is. So, from our viewpoint, we don't have access to a lot of the data regarding, are there specialty beds that are needed? Is it for those with developmental disabilities or co-occurring disorders or geriatric beds? And so I think that is something that the state can continue to really look at as far as collecting that sort of data. Okay, Steve.
And I'll just mention real quick, just kind of a real-life example of what I see at Cedar Creek. So we have 30 child and adolescent beds. It's 12 to 17 years old. And as Jamie mentioned, during the summer months, I may have 12 kids on the unit, on those 30-bed units, where the rest of the year it's pretty close to capacity. But what happens, though, is I don't have that seasonal dip on my adults. I'm running close to or at capacity all year long. And so we're turning away 15, 20, 25 adults a day, as I said over here, with 18 kid beds open. And it's just, it's hard to treat our community with those open beds sitting there that I can't flex to adults. So it is real that we're seeing, during the summer months, during the holidays, during the Christmas season. So hopefully we can see some movement on that. Then I think the last thing that we want to discuss is just a electronic health record investment. And you'll see in the slides, mostly on the next page, where we have an example of a bill that is moving through Texas right now. I believe it's getting ready to go to their governor for signature, where they're investing on a match program with behavioral health hospitals in Texas to bring an electronic medical record to those facilities. And what you'll find in Michigan right now is these private freestanding psychiatric hospitals like us do not have EHRs. We're still doing, believe it or not, everything by paper, hand charts. And it's, for another real life example, it's really impacting my ability in St. John's in the middle of the state to recruit physicians. And I recently had one in the last 3 months that we're getting ready to sign the contract, and he, I guess, discovered that we don't have an EHR, and he backed out. He said, I just can't treat people safely and effectively without an EHR. So you'll see some other things listed here where obviously there's an access to care. That EHR is not allowing our providers, our physicians to talk to other, hospitals, other providers. Everything's by phone or email. We don't have a secure exchange of information. We're seeing that as auditors, the state of Michigan comes in, our accreditation bodies come in, they're having to swipe through hundreds of pages of charts. The clinician burden, just the documentation that they're having to do and create their own templates in Word and everything else like that, things get lost. It's not smooth then for a coordination of care with our staff then as we're sharing information back and forth as a treatment team. Patient satisfaction as they're sitting there waiting for, basically scribes to write out notes. And then again, as I already mentioned, the physician recruitment. So just hopeful that this committee could take a look at the House Bill 1621 in Texas and see if there's something similar that we could do here in Michigan with a match program where we're responsible for some of the costs. But it's based on what we've researched, and it's very similar to what they're seeing in Texas. It's about $1 million per hospital up front to get these implemented. So what Texas is looking at is a $20 million investment for these private hospitals.
I just wanted to add too, part of the challenge is for us to really respond to some of those data collection efforts that are being put in place. So the bed registry that is now live within the state. In our facilities, because we do not have an electronic health record, that is a manual entry point that has to happen multiple times per day for our staff to go into the system and be able to enter all of that information about how many beds we have available. It would be much easier if we could just click a button and that data could be transmitted electronically. And I would argue too that we're going to get better data. It's going to be more accurate if it is built into the system. So behavioral health providers being excluded from those federal programs to fund technology has really been a challenge historically for our freestanding psychiatric facilities in the state of Michigan, and just really kind of lays another barrier on top of what we're already experiencing. Okay, this is our contact information. We would be happy to answer any questions you might have for us.
Thank you both for being here today. I think I'd like to start by going back to certificate of need. For the benefit of the committee, can you just kind of explain, that process, what that looks like, and maybe, who's in charge of that?
Yes, I will to the best of my understanding. It is a complicated process. Whenever there is any type of hospital-based need, whether it be psychiatric or acute care, there's a certificate of need process whereby we as providers have to justify the needs in our community to be able to add more beds. It is a several months long process to add additional beds. It is usually based on occupancy data, as there is a set number of general psych beds, and then there are a set number of specialty beds that are determined by the certificate of need process in the state every year. If that is helpful. There's a lot of paperwork involved.
And who administers that program?
That's the state of Michigan.
Okay. What kind of changes, in your opinion as providers, need to happen in the certificate of need process?
That's a good question. I mean, I think ideally the flex bed issue that we spoke about earlier would be a very quick win for the state. Havenwick currently has a 32-bed child and adolescent unit compared to 183 adult beds within our facility. Right now, we have 12 open child and adolescent beds. Those beds, in theory, could be flipped to adult beds. We are at capacity for adults right now. And so there is just this continuous deflection where we are deflecting thousands, and I'll put the data back up as well, thousands of adults just between January and May for this year alone. We deflected 4,626 adults, and that is only due to bed capacity. So if we had the beds available, those are referrals that we could accept within our existing facilities here in Michigan.
What typically happens with those folks? I mean, if you don't have capacity, we're hearing over and over that other people don't have capacity. Where are they going?
Unfortunately, sometimes they sit in the emergency department for days and days. Sometimes they are then discharged when they are stable enough to be sent back out into the community. Other times, they might sit there for days and a bed opens up and we're able to accept them, or some other facility is able to accept them. But oftentimes they don't go from the emergency department to a state facility, for example. There are many steps along the way. And part of the challenge too with the not having enough state beds, I mean, we have had some adults at Havenwick who have been with us over a year, close to a year and a half, upwards of 2 years, just waiting on a state bed. And again, we feel like, we're happy to do the work and be that safe place for the person, but it's really a disservice to them. We are not set up for 8 to 2 years. We're set up for 2 weeks of treatment and really stabilizing that crisis, so.
And I guess just one more kind of question along that same line with the flexibility with beds and certificate of need. There's an understanding that, children in this situation should definitely be segregated from adults. Are your facilities equipped to be able to convert those beds and kind of be able to move them back and forth? The safety concerns, are they all addressed?
Yes, and that's part of the licensing process as well, that, those beds have to be separated. We currently have 8 different units at Havenwick, and so we're able to move populations around as needed. But as we kind of look to, grow and add additional beds and new facilities, that's always top of mind, to have that flexibility in population.
Yeah. And we have the same at Cedar Creek, so I even have a set of double doors on all of our units about halfway down the unit, so I can close them off as needed. We were able to even utilize it during COVID, so if we had COVID-positive patients, we were able to create a separate wing for those COVID-positive patients, and then have the clean patients on our regular unit. So we definitely have the structure already to flex as we need to, if we're allowed to.
Thank you. Representative Green.
Thank you. So thank you for your presentation. And I'm not a behavioral health expert, but it sounds like there is definitely a need for long-term facilities as well. And so, and I think I know the answer, but I'm just going to ask it. Can you explain how, closing all of the state behavioral health facilities, how that has really impacted the population? Just go in more detail about that.
I think generally speaking, part of the challenge is really making sure that we have an appropriate continuity of care available in our community. The state of Michigan has done a great job with its CCBHC projects, with standing up crisis stabilization units, and really making sure that individuals have that kind of first point of contact and can hopefully avoid these higher levels of care. But the reality is that there are some individuals who need that kind of long-term day-to-day care. And so, the result is, like I spoke to, we have individuals who are in facilities that are not set up to be therapeutic for that period of time. We have wonderful group curriculums, but they repeat every 14 days. It's really, I think, a disservice to our communities. Oftentimes what will happen is if there is some sort of group home in the community that will accept the patient while they wait for a state hospital bed, they may get discharged from one of our facilities, and then they're waiting, for months in a group home waiting for that bed to open up. So I think we just don't have enough options for individuals who really do need that long-term 24-hour supervision and care to be able to keep themselves and their community safe.
And I would just
Okay,
say real
yeah.
quick, then oftentimes what happens is we're sending these kids out of state, which, then they're away from their families, they're away from their caregivers, maybe a legal guardian. And then often it also takes maybe 2, 3, 4 weeks to find a bed even at these residential facilities. So we have a kid, as Jamie just described now, that's really going backwards in their treatment because they've already been through all of our programming. So, but we're sending many kids out of state, Indiana, or wherever a residential center may be available.
So do you think that there have been lessons learned in the last 40 years that there is still a place for community living at these hospitals for individuals who just may need that extra care instead of living independently or in those neighborhood group homes?
I mean, I think we need to find, there needs to be a middle ground, and we really need to recognize the individual needs and build a treatment plan and program that is appropriate for those needs, depending on successful treatment in the past, medication regimen, family support, what that looks like. But right now, we don't have a lot of options.
Representative Cerniglu.
Thank you. So if there is a bed available, do you ever have to turn people down because of their acuity of care or potential for violence? Is that an issue?
You want to? Sorry. We pride ourselves at Havenwick for really being able to take high acuity patients that have an increased level of need. Our hospital's been around for over 40 years. We have a very well-trained staff. That being said, there are still individuals that we are not able to take because of behavioral acuity. And those really need some sort of specialized care or units. Currently, our facilities under construction will be adding an additional 8 beds, which will give us 2 8-bed units. And our plan is to develop psychiatric intensive care units. And so we will have specialized programming, we will have specially trained staff. So we are able to accept those patients who are kind of on the extreme end of that acuity. That being said, we have people come in every day who are violent, who have co-occurring substance abuse, who have co-occurring intellectual and developmental disabilities, that may have behavioral challenges. So this would just really be that highest level that we're trying to meet the need for. And I think the other point that is important is that, a lot of our facilities, we have 30-bed units, we have 40-bed units, and so when we do accept somebody who is that highest level of acuity, not only do we have additional staff, but we often are blocking beds around them so they can have a private room, and the challenge is really finding that balance.
I want to thank you both for your testimony today. Appreciate it. And we're going to move on to our next guest. Thank you.
Thank you so much.
So I'd like to welcome Dr. Kai Anderson, who will be testifying on Zoom today. Dr. Anderson is the Associate Director of Psychiatry at CMU's Residency Training Program and their Director of Psychotherapy Training. So Dr. Anderson, if you could begin whenever you're ready.
Hello, can you hear me?
We can.
And are you able to see the screen?
Yes, ma'am.
Okay, I can't see the slides, so I will just progress as I seem fit. So first of all, thank you, Chairperson and members of the committee, for allowing me to speak with you today. I'm Dr. Kai Anderson, a child, adolescent, adult, and forensic psychiatrist. I'm going to focus my talk today primarily on children and families. I work with children and families across emergency departments in my outpatient clinic and inpatient psychiatric units here in Michigan. I'm here today to speak not only as a physician, but as someone who has walked alongside countless families during their most painful hours, waiting without answers for a psychiatric bed to become available for their loved one. Let me begin with a story. Earlier this year, a single mother, who I will call Ms. Jackson, to protect her privacy, brought her 10-year-old son to the emergency room after weeks of uncontrollable aggressive behaviors. Her son is seeing me and has extensive support in school and with therapeutic services. She has been adherent with all treatment recommendations and was no longer able to keep him, her other child, or her son safe due to his aggression. So she sought help by going to the emergency room. But no psychiatric bed was available. Not in that hospital, not in that county. The case manager tried to negotiate an agreement with an out-of-county hospital, but they were unsuccessful. The mother and her child waited 3 days in a crowded ER. The child was frightened and confused. The mother, a single parent of 2, was forced to choose between staying with her son while also attempting to care for her younger son at home. She told me with tears in her eyes, "I fear like I am failing all of my kids." Eventually, the child was admitted to the pediatric unit where he was treated by a psychiatrist for the next 7 days. A psychiatric bed was never found. I have so many stories like this. Just this weekend, a mom called me at 4:30 in the morning. Her child was aggressive and suicidal. She had been seen by a mobile crisis team and they recommended hospitalization. My patient's mom was overwhelmed and felt unsupported as she was told that CPS would be called if she left the hospital while they were attempting to find a psychiatric bed. She asked me, "What about my other child? What is my duty to her? Who's going to take care of her? Maybe she just sign off on my parental rights." I talked with the mother, and she eventually agreed to stay at the hospital while they attempted to find a bed, and luckily they found a bed within the next 24 hours. But she needed help then. She didn't need to have to wait for a bed to be found. Unfortunately, her story is not unique. The data is clear. Michigan ranks 47th in the nation for inpatient psychiatric hospital bed availability. So I'm very glad to hear that we are enhancing our ability to have more beds in the very near future. As I'm sure you all know the data, that in 2022, Michigan only had 1,945 licensed psychiatric beds, which equates to 19 per 100,000 residents. Far below the national minimum recommendation of 30, and less than 1/3 of the optimal target of 60 beds per 100,000. We need 1,065 more beds to meet the minimum standard and over 3,000 to meet optimal care thresholds. This crisis is even more dire in rural and northern Michigan. In the UP, only 2 hospitals, UP Health System Marquette and My Michigan Medical Center Sioux, offer psychiatric inpatient beds. While the UP needs 75 adult beds, it currently only has 57, and due to staffing shortages, which are common among many institutions, fewer than that are operational. For example, UPHS Marquette has 37 licensed beds, but only operates 20 due to staffing shortages. My Michigan Sioux has 20 licensed beds, but can only operate 12. Statewide, this gap is paralyzing. There are over 218 behavioral health professional vacancies across Michigan hospitals today. The UP has only 1 child psychiatrist serving the entire region. And HRSA projects a national shortage of over 187,000 physicians across specialties by 2037, with behavioral health especially hard hit. Meanwhile, the burden lands squarely in our emergency departments. In 2024, 63% of patients waiting in Michigan ERs are waiting for behavioral health beds. And there is a discrepancy amongst the insurers, and Dr. Albee will talk more about that in terms of the individuals that are waiting longer for beds. There were 1.2 million emergency visits where behavioral health was a presenting concern. And unfortunately, our ERs are not designed to manage psychiatric crises for days at a time. And yet, that's what families across our state are enduring. So what is the human cost? We talked often in terms of beds and capacity, but I urge you to see these as people, children, parents, and caregivers caught in crisis. Families like Ms. Jackson are living with impossible choices. Do I keep my job to stay by my child's side? How do I keep my other children safe and cared for while I wait? What happens if I leave for just a moment and my child attempts again? These are not policy hypotheticals. These are the daily, excruciating realities for Michigan families today. We have created a system where parents in crisis are forced to feel like failures because we have failed to build infrastructure to meet their needs. But there's good news. There are multiple opportunities for action. The Senate Bill 219 aims to modernize assisted outpatient treatment procedures and improve continuity of care. There's current legislation to enter the Interstate Medical Licensure Compact, which will streamline physician licensure across states and improve recruitment, especially in underserved areas like the UP. In addition, MHA recommendations include, as we've already heard today, expanding those swing beds so that we can flex the beds between children and adult units in time of need, and also reimbursing hospitals for services provided to patients that are boarded in ERs while they await psychiatric treatment. And here in the UP, in Marquette, they recently launched an intensive outpatient program to reduce unnecessary admissions and to provide continuity of care in community settings with close monitoring. But although these policies are wonderful, they're not enough, and I urge you to consider the following recommendations. We need to continue to expand our psychiatry bed capacity statewide and prioritize high-need regions like the UP. We need to fund behavioral workforce development, including making sure the programs for loan repayment and tuition support remain viable. We need to have salary incentives for rural providers. We need to have incentives for child and adolescent psychiatry. We need to make sure that the statewide bed tracking system is working and is efficient to eliminate unnecessary ER boarding delays. We need to expand wraparound supports for families, including offering paid family medical leave for parents of hospitalized minors, emergency sibling care, and on-site case managers and peer supports. In addition, we need to provide sustainable reimbursement for ERs and community hospitals who are de facto mental health providers due to our systemic gaps. We need to expand behavioral health emergency rooms to allow these patients to receive care in a setting that is conducive to their needs. We need to expand the specialized units in our hospital to address the needs of patients with developmental disabilities and mental health needs. And we need to reduce the bureaucratic challenges to PACE patients in other counties or patients that may be difficult to care for. We also need to expand our use of crisis stabilization units. I'm working at a hospital today. You have a child that's been in the hospital for 2 weeks. We cannot find a place for him in a crisis stabilization unit because so many have closed. We also need to provide additional resources for youth in foster care who are in need of placement post-discharge from psychiatric facilities. I know we have many challenges. Budgets are being cut, Medicaid is being cut. There's lack of information on outpatient resources, which inhibits discharge. There's a decrease in residential youth treatment programs, but it's so important to make this a priority. Mental health is health. Without mental health, you have no physical health. But right now in Michigan, we are treating psychiatric care as optional, delayed, or someone else's problem. We must stop treating children in crisis as numbers on a waiting list. We must stop expecting single parents to shoulder the entire burden of a broken infrastructure. And we must stop accepting a system that fails the very people it is meant to protect. Michigan has a chance to lead. Let us seize that moment. Not in the next budget cycle, not after the next election, but now. Because no family should ever have to spend 3 days in the ER wondering if help will ever come. Thank you for allowing me to speak today. I welcome your questions.
Thank you, Dr. Anderson. So my first question, I'd like to kind of go back to where you just were at with the ER. When a patient comes into the ER, typically, you're coming in for medical treatment, but if that medical treatment is mental health treatment, what does that look like for them if they have to spend multiple days there? Are they being treated? Is it just kind of a holding pattern? I mean, what does that actually look like?
So every facility is different, which is part of the difficulty. There's no standardized availability for behavioral health providers in all the facilities. So typically a patient is seen by the emergency room physician and a consultation is placed with a behavioral health provider. If the patient has Medicaid, they have to be seen by a specialized individual to assess them within a certain period of time. So they should be seen within 3 hours. Sometimes it may be longer than 3 hours. If they have commercial insurance, they can be seen by another individual, a social worker that works in the facility, or a psychiatric consultant. So it varies depending on the availability of that psychiatric consultant. And that is one of the challenges, is that we need to have more availability of psychiatric consultants in the emergency rooms to see these patients. While they're in the facility, as an example of my particular patient, he was not given psychiatric treatment while he was in the ER, but once he went to the floor, the psychiatrist was available to provide a psychiatric consultation, provide treatment on the inpatient pediatric unit, which is where he was ultimately placed. So it really depends on the capacity of that particular institution as to what kind of treatment they will get and where the treatment will be delivered.
Thank you for that. You also mentioned minimum recommendations and optimal recommendations. Michigan is lagging behind in both of those numbers. Can you just kind of talk about that a little bit? Like, where do those numbers come from? How does that national average get determined? And what is included in the count in Michigan for those numbers?
I'll try to answer that to the best of my ability. As far as I know, that information comes from a database based on the amount of providers that are needed to treat a population. And the basic formula is 19 beds per 100,000, 30 beds per 100,000 residents. Our current data is 19 beds per 100,000 residents. So it's based on national standards regarding what is the minimum amount of providers to treat that population.
And then I just had one other question before we'll see if anybody else does. In your role in the university, what challenges are you seeing in recruiting? We know that sometimes it's not just the actual physical beds, right? You mentioned it's the people to provide treatment. Are we getting people to come into this profession? What does that look like, and what things are being done to try and add bodies?
Here at CMU, where I'm the Associate Program Director for Psychiatric Residency, we have a very skilled recruitment staff, and we've been lucky and able to retain and recruit several psychiatric residents who have stayed in the area. So I definitely like to give kudos to CMU for their work. And they've done that in part by offering specialized programs to incentivize individuals to stay in the area, which has been very helpful and helped us to recruit individuals. I think we need that in more rural communities and more focus on family practice, psychiatry in rural areas. And there's several programs in Michigan, including Michigan State, that also focuses on that. So we just need to make sure that's a priority at our training programs nationwide.
Representative Green.
Thank you so much for presenting. If you had like a magic wand, I guess, how would you, or we're in our position and we could fix things. If there was a top thing that you could do, what would that be? And I know that's a weird question, but I mean, this is an area I'm not an expert in, and so you are our expert, and I would like to help you and fix this. I see the problem, I just don't know how. And so I guess that's kind of what I was asking with the magic wand.
I think the first thing would be to try and reduce the cuts to the current programs, to Medicaid funding, which is affecting everyone because of those cuts to those programs, which is affecting our children, our families, our adults. That would be the first priority. The second priority is parity in mental health and physical health. We need to make mental health a priority and make sure that there's parity in funding and reimbursement and availability. I think those would be the two top priorities for me. In addition, just providing more support for individuals that struggle with psychiatric illnesses, whether it's the individual or their family, in the form of having additional leave and additional support in home for those individuals with additional programs to provide in-home services.
Thank you. Representative McDonald.
Thank you, Chair. So I'm interested in the relationship between the shortage of psychiatric beds and the shortage of behavioral health workers. And of course, I know we hear all the time about beds, but sometimes beds are really just not about the physical situation, but the workforce situation as well. How much of a problem is that in the state of Michigan, do you think? And is there anything we can do to help on that?
I'm sure there's an echo. I didn't hear the last part of your program.
How could we help with workforce issues and increase the workforce for behavioral health?
Just I want to make sure I heard the question. How can we improve the workforce for behavioral health? Was that the question?
Yes, part of the question being, I don't know why it's muffled for you maybe, that how much of the bed problem is actually more about the workforce and less about the physical beds and facilities.
Thank you for that. I think staffing is a challenge at many institutions. And we need to make sure that we have those feeder programs, whether it's a technician, whether it's a nurse, whether it's a PA or a nurse practitioner. We need to make sure that those programs are available and funded, and that individuals have incentives and loan repayment programs to enter into those programs. I think that will help tremendously. In addition, we need to continue to improve our institutions and provide additional benefits at the institutions to retain our employees.
This is a kind of rough time for that.
I'm sorry, I didn't hear the
This
last.
is a challenging time for that right now. I take it, especially with Medicaid cuts coming.
Yes, it is.
Okay, seeing no further questions from the committee, I want to thank you, Dr. Anderson, for your testimony today, and please know that the committee appreciates your insight on this issue. Our next presenter, also joining us on Zoom, is Dr. Zakia Alavi, who is the Chief Medical Officer at North Care Network, which is a prepaid inpatient health plan responsible for serving Michigan's Upper Peninsula. North Care manages behavioral health services under the 1115 waiver, Healthy Michigan program, and substance use disorder community grants through its contract with MDHHS. They also provide comprehensive mental health and substance use disorder services for individuals with serious mental illnesses, emotional disturbance, intellectual and developmental disabilities, and substance use disorders. So, Dr. Alavi, please begin whenever you are ready.
Thank you, and thank you for inviting me to speak today. I just want to make an addition to what you said. I am the Chief Medical Officer for North Care, which is Region 1, but also for Region 5, which is Mid-State Health Network, which is Mid-Michigan. Before I go any further, do you all understand how community mental health system is divided in the state of Michigan? If not, I could give just a 2-second overview, because that might help.
I think it would be good to have an overview. We would appreciate
Sorry?
that. We would appreciate an overview.
Okay. So the mental health benefits for patients who are on Medicaid in Michigan are carved out from the main Medicaid pot of money, if you will. And the mental health funds are dispensed through a different system, and that's the system of community mental health clinics. They used to be back that system started in the 60s, up until the mid 2000s. It was a conglomeration of each county having a community mental health system that was funded directly and got money directly from the state of Michigan Medicaid funds for people who were deemed severely and persistently mentally ill, according to Michigan's mental health code. In mid 2000s, the state of Michigan, MDHHS, said there are too many players here, hard to get consistency. They brought all of these together into 10 regions, each region covering now multiple counties. So now there are 10 regions in Michigan. Each region covers multiple counties. So for example, Region 1, which is where I work for, all of Upper Peninsula has 5 community mental health clinics as part of that. Region 5, which I also serve as their Chief Medical Officer, we have, I think, 12 counties, 12, maybe more, 21 counties, sorry, and 12 community mental health clinics. So it's complicated, you see, right? There are different levels of it, but I am a child psychiatrist. I'm also an adult psychiatrist. And Dr. Anderson was wonderful in her presentation because I couldn't have done it better. She gave the patient stories, the reality of advocating for patients, the burnout that comes when you're unable to do so, and also an overall systems-based view in terms of numbers and stats. Let me, if you allow me to, let me give you a slightly different, more meta perspective, if you will. So I represent myself. I mean, I'm here as the Chief Medical Officer for 2 of Michigan's Medicaid regions. They're called PIHPs, just a mouthful. But I speak for them, and I speak for my patients, and I speak for myself, mostly my patients. I trained in Detroit. I learned to speak bluntly and passionately to be heard. A woman with an accent, a woman who is brown and wasn't born and raised here. You had to work hard to be taken seriously, right? And so Detroit gave me all that. That's my home. That's Wayne State University. That's my home. That's where I was trained, and I specialized in adults and children. So I want to draw your attention to some issues, some very alarming issues that the shortage of beds, of course, is an alarming issue, but there are issues that underlay that major issue. So Dave, and I'm going to read a prepared statement. English is not my first language, so if I stumble, I apologize in advance. So every day we contend with the increased acuity and lack of appropriate treatment settings. The complexity of cases has escalated due to the pandemic and the pandemic recovery processes, loss of natural supports, and the prevailing negative sentiment about community mental health systems and mental health in general. There is a marked shortage of psychiatric beds, and this is the interesting part that I don't hear talked about. The shortage is there for all people, but there is a really bad shortage for Medicaid patients. Since the 90s, various political and fiscal policies have systematically reduced state-funded inpatient psychiatric services, burdening private hospitals to provide services that they're not typically able to provide. The two hospital CEOs very kindly and very appropriately mentioned that there are certain patients in our world, in the world of psychiatry, child psychiatry for me, and some adult psychiatry, that need, that long-term stay. But in the 90s, in 80s and 90s, there was a wave of anti-institutionalization for psychiatric patients, which was not completely wrong, I have to say. But I think the tide or the pendulum has swung too far to the other side. So people were deinstitutionalized and brought out of state hospitals, and the beds were closed and hospitals were closed. But there wasn't enough infrastructure or support or funding even to manage these people once they were brought out of these institutions. That leads me to another problem. So most inpatient psychiatric hospitals, now I trained in inpatient psychiatric hospitals, there are two sets of criteria that, and I'm giving you this as an inside view. I don't know if our hospital CEOs would necessarily agree with that, but when we admit a patient, when we send a patient to be admitted, there are psychiatric beds, and then there are Medicaid psychiatric beds. And so for my Medicaid patients who are typically sicker with fewer psychosocial and community supports, that shortage is even more acute. Most of the patients that you will find boarded in the ED or the ER, the emergency department, you will find that they are patients on Medicaid, kids on Medicaid, kids who have autism and are being, the treatment is covered by Medicaid. So there's a shortage of beds, but there's really a shortage of Medicaid beds. It is really crucial to recognize that a part of this issue, this lack of psychiatric beds, was completely inadvertently exacerbated by the policies of the community mental health systems in the 1990s and 2000s. And I worked with that system. I support that system. There are so many good things in it. But back in the 90s and 2000s, hospitalizing a patient was a bad word. I remember being a relatively younger physician who had completed her fellowship and was like really gung-ho about, I'm gonna change the world, and this is my home, this is the US, and I come from the third world, and we're gonna change this world, and we have all of this, and Medicaid is there as a safety net, Medicaid is there as a safety net. And I would get in trouble with the clinics, the community mental health clinics I would work for, because they'd say, well, doctor, we hired you to treat them in the community, not to hospitalize them. That's just institutionalization. And I'm not naming names of any of these clinics, but I'm telling you, many of my colleagues don't work in the community mental health system because of those kinds of pressures. We are asked to treat patients who can't be treated in an outpatient setting. So a part of this current crisis stems from those times where, because hospital admissions were so tightly controlled and not authorized by community mental health systems, by Medicaid, prepaid, inpatient health plans, that hospitals started to shut down. I mean, back in the day, I remember I used to, when I first finished my my fellowship, I was in private practice and I worked in Hillsdale, Michigan. I don't know how many of you know Hillsdale, Michigan, but it's a very small place. Well, it does have Hillsdale College, but the college is a thing aside from the rest of Hillsdale. It's very rural. And I can tell you that even the small community hospital there used to have a psych unit. Then I used to, I lived in Jackson, Michigan for a long time. And the small community hospital there had not only a adult psych unit, they had a child and adolescent psych unit. I mean, that was how it was up until the 90s and early 2000s. And those places, those beds, those units closed down one after the other to where you can't find them. We used to be able to have, not in every town, but probably no more than 50 miles or so, maybe a little bit more in rural areas, get a patient admitted, especially for me, child patients admitted. You can forget that. If I have a patient that needs to be admitted, and I see patients in Jackson County, they go all the way to, Havenwick Hospital, or, easily 50 miles plus. If the weather is bad, the parents can't go to visit these kids. If the weather is bad and the kid is discharged and the patient doesn't have the car, they have challenges. CPS is called because the kid is considered abandoned. I mean, I can tell you horror stories where people have lost their kids because of these kinds of problems. Anyways, so that's the background, which led to where we are now, which is the same CMH, the same state of Michigan, the same Medicaid funded entities are now saying we're screaming for beds and there are none. So we need a dialogue. We need a dialogue between the hospital systems. I'm glad that I was here today while I heard the two hospital CEOs speak. It's really encouraging for me to hear for a poor, simple, practicing physician, that there are people at the hospital level, the CEOs, they're cognizant of this fact, and they're developing more beds and developing more services. But we need something more. Just having more beds isn't going to cut it. We need to have some sort of an agreement, an understanding between the hospital systems, the private hospital systems, and the community mental health providers. And I hate the term provider. It dehumanizes the patient and the physician. But we need them to speak a common language. And I'll tell you why that doesn't happen. Your hospitals, any emergency room, psychiatric hospital, cardiac hospital, the ethos is the medical model, right? So when a patient who gets admitted, who gets discharged, who gets what services, it's strictly a medical model. The physician in charge, the attending physician or physicians, will determine the level of care, when they're ready to go home, so on and so forth. It's a little bit different for psychiatry. because, and I'm speaking for Medicaid, because actually Dr. Anderson spoke very eloquently earlier and explained how when there's a psychiatric patient in the emergency room doctor, or the ED doc, will say, okay, we need psych to come and evaluate. Now, this is the beautiful part. The psych that comes to evaluate are not psych doctors, right? They are referred to as clinicians, and they're all non-medical folks, unless the patient is lucky enough to be like at Wayne State or, one of the training hospitals, which are far and few in between, where, residents and interns like me and Dr. Kai, when we were residents, are working 80, 120 hours a week on call perpetually, and that's fine. But those places are few and far in between. And so these patients are then evaluated by non-physicians. And if it's a Medicaid situation, the non-medical staff may or may not authorize that admission. It used to be that actually a lot. And what would happen was that these patients would be then, quote, diverted, end quote. That was the term that's still used actually, to be sent to a lesser, not hospital-based setting. So what that did over time is that it increased the severity of the presentation of the patient. Because so keep in mind, mental health, just like physical health, is on a spectrum. People who are mild to moderate actually become severe, and people who are severe can actually get better. And so that takes me to my next thing, which is the mental health code. The way it's written and the way Medicaid, Michigan Medicaid and Michigan Mental Health Code is written, it talks about providing care, Medicaid care for severe persistent mental illness. Now that is a concept that probably is not in, Dr. Anderson, what do you think? Like probably 100 years ago that went out the window, right? In psychiatry. There is no such thing. Moderate or mild depression is the one that untreated will lead to suicide. Somebody who's floridly psychotic can be brought back to reality and can function reasonably well in the community if you catch them at the right time, if you provide the right supports. So we have these systemic issues in terms of what happens when a patient is boarded in the ED. So when you hear in the news, when you hear from, your constituents, my kid is sitting in the ED or my family member, what they don't know is there are all these other players. It's not the same if you have a heart attack. It's not the same if you have a seizure, but God forbid you have a psychotic break and you are, I promised myself I'm not going to use impolite words, but you're in big trouble. The other issue is this underfunding of Medicaid-based services. And I'm going to speak for our friends, the CEOs for the hospitals. Medicaid patients, for everything, physical health or mental health, the payments are less, much less. So when hospitals take our patients, they are taking them at a loss. It's the same thing, by the way, for people practicing, physicians practicing as outpatients. When I did a decade, 10 years of private practice, I'll be honest with you, I didn't take any Medicaid, okay? Because I couldn't afford to keep up a practice, one-person practice, being on call 24/7, 7 days a week, and accept Medicaid. So that was back, in the 2000s and 90s. There is a huge mismatch between how much a hospital gets for Medicaid bed versus, without naming any names, a commercial payer. Therefore, Medicaid bed crisis, psychiatric bed crisis is more acute for us. The state has just come out with, what do they call it, procurement policy, which is another, you realize we are in a very critical position here. Suicides have increased. Youth suicides are at an all-time high. And the state of Michigan has just come out with this whole idea of reprocurement, which is actually, in theory, is not a bad thing. Talks about taking the 10 regions and narrowing them down to 3 regions and making them hopefully better and easier to manage. And all that sounds lovely, but there is no time. This change is supposed to happen next year. The infrastructure takes time to build. People need as it is, there are no hospital beds. Can you imagine with regions coalescing and becoming bigger regions and the same hospitals being the catchment area, the catchment places for much bigger populations? It's going to be a nightmare. I tell you, I've been in practice for 25 plus years. I have a daughter who's a physician. She's training to be a psychiatrist. And I told her, actually, when she chose to go into psychiatry 2 years ago, I said, don't. Why are you doing this? You choose something else. This is a level of heartburn and heartache and nervousness and tension that no other specialty in medicine lives with. No other specialty in medicine is faced with the fact I have a suicidal patient or I have a psychotic patient and I have nowhere to send them. So,
Doctor?
Sorry.
Oh, no problem. I want to make sure that we have time for questions, so if you could maybe have a concluding point, and then we'll move into questions. Thank you.
Yes. Thank you for the reminder. So I'm just going to be very quick now. Some recommendations. The first one involved medical leadership in systemic changes and systematic changes when they're being made in behavioral health, both at MDHHS, at the hospital level, at the community mental health level, and at your level, the level of legislature. The second one would be, we need to look at the Michigan Mental Health Code to understand where it aligns or doesn't align with the current evidence-based medicine. Psychiatry is also medicine. So, we need to bring it into this century. We need to address staffing retention and staff training. Our staff, and I forget about the doctors, which is a whole other thing, but the staff, that makes the bulk of our people who manage our patients in the community are paid around minimum wage. They need support. They need help. We've lost so many people through COVID and then post-COVID because people will go work for McDonald's. They'll go work for the school system. They'll do something else. We just don't have the money to pay them. And then the last is we need to tackle the underfunding and lack of standardization of inpatient psychiatric hospital admission process. There needs to be parity in payment, and there needs to be a single accepted standard of care for all when assessing a patient. And that standard needs to be the medical standard, the same that applies to all other specialties. And that will be all. Thank you for listening to me.
Thank you. We're going to go into some questions. We'll start with Representative Green.
And mine is more or less, not necessarily, I'm feeding back, a question. It's to start engaging in the conversation, because we keep hearing repetitive over the underfunding of Medicaid, and I hear that from my own doctors and as well. And I guess, and this is a debate we need to actually have, that I do believe we need to pay more for Medicaid because they're getting the same treatment, therapies, and utilizing the same services as a private pay patient would. But I understand we only have so much money. And so this is where we need to have the hard conversations. And I know we don't want to talk about that, but what are the measurements for Medicaid? What qualifies for Medicaid? Who can be on Medicaid? Because I think if we shorten that population, then we're able to pay our doctors more and increase the funding. But I think it seems to me the problem, and this is just me deducing this and listening to this over the past couple of weeks, is we only have the same pot of money and we're spreading it thin. And it's a harsh reality. It's not something everybody wants to hear, but I do believe that we need to have that parity in payment as well, because you want everybody to have the care that they need with their conditions that they have. And if they're on Medicaid, they should very well be there for a reason, because they can't take care of themselves. And I think that was the intention and the heart of what Medicaid was. And I think those are the conversations we need to start engaging with each other, and the reality of what Medicaid is. That's so you don't have, it's not a question, it's just a conversation starter.
Well said. I agree with you.
Representative McDonald.
Thank you. I have two questions, if I may. One, I was thinking about the question of, I've heard about many groups talking about PIHP reform, and if that can bring that can bring down costs because it's more efficient. But then when you were talking about 10 regions down to 3 regions, were you actually talking about PIHP reform, and that you think it would be
I was referring to that,
cataclysmic, it
correct.
sounded like? Is that what you were talking about?
Yeah, yes, I was. Yes, I was.
So to you, that is not a good idea?
Look, I'm not a legislator, and I am just a simple physician in the trenches. It is not a good idea from my point of view, only because the timeline is ridiculously short. I mean, we are struggling with major shortages right now. We have suicides climbing. And you do this reconfiguration, and it's supposed to go into effect October 2026. Where is the time to build capacity? Where is the time to build networks and infrastructure? Where is the time to do intentional, thoughtful engagement with the stakeholders? It's just not enough time. I think in principle, honestly, regardless of who I work for, standardization is good. I would love to see a single payer system, and probably I shouldn't even be saying that. I don't know
It's okay.
politics much, but you know, the less layers, the better for our patients. But you don't want to jump into these things. You know, you want to ease into them. This seems reactive and too soon. I worry about my patients. My patients are worried about themselves.
Okay. And my other question is, I agree with the idea that we have this pot of Medicaid. I do a lot of work in disability policy, and I'm very aware of how important Medicaid is to helping people live independently. I'm also aware that sometimes private insurance companies just can move around the reimbursements they give to providers however they see fit. So there are some times when a provider might say, okay, I'm going to have to cut off this insurance company, anybody who's covered in Medicaid by this private insurance company, because they're only paying $67 an hour now instead of the $80 they were paying last year. It's all very complicated. What is going to happen if we see these massive Medicaid cuts at the federal level to any and all of these problems?
Nothing good. Nothing good. We are, I don't know how many people realize this outside of those of us who are in the trenches. We are sitting on precipice of disaster. Our young people are dying. Our families are unable to care for them. The family systems are fracturing because of the pressure on them. I have patients with, and I don't want to take up more time, but really this it's a reality. A single parent, or heck, a 2-parent household, kid with autism, kid with severe bipolar disorder, maybe they've adopted a kid with severe reactive attachment disorder. They can't go to work. They can't. They lose their jobs. Or if they go to work, they don't make enough money to get adoption subsidy. They don't make enough money to get Medicaid benefits. So, you know, there have been trickle-down effect, right? So people don't want to adopt. People don't want to foster. People don't want to be engaged in all those sorts of good good Samaritan activities that our society was built on, fostering kids, providing support, providing supportive networks. How do we do that? And I should get off my soapbox now.
No, thank you. So I'd like to go back and ask maybe some more UP specific questions, because I think you have an insight into that maybe some other providers haven't had. So as a physician and an administrator of one of these health systems, how is recruiting and retaining employees in an area like the UP differ from, your role at Midstate?
How much time do you got? It's a big challenge. It's a challenge that's unique to the UP because of how few people live there and because of how big geographically it is. It's common to drive 2 hours to take your kids to go see an orthodontist. To get crisis mental health services, you're looking at a drive of about 4 hours. Staff, again, very limited people who live there. And when they live there, do you know the rate of suicide in UP, Michigan's Upper Peninsula, is probably one of the highest in a region in the entire country. And I don't remember the exact number, but I remember speaking about it last year for Northern Michigan University. And everybody, if you just go to the UP, my friends, you talk to anybody in the field, outside the field, they know somebody, a family member, a neighbor, a friend who has died from suicide. People are hurting there. And so the recruitment of mental health workforce is very difficult. So I'll give you an example. In my spare time, I am also involved with teaching medical students and training doctors. And one of my medical students trained and became a psychiatrist over in Michigan's Upper Peninsula. Well, I've known him since his first day in medical school, and I said to the community mental health people, we need to hire this guy. I've known him. He's good. He wants to live in the UP. He's even bought a house because he said to me, Dr. A, I want to live here. This is a very peaceful community. Do you know what happened? My CMH folks were unable to offer competitive wages to this brilliant doctor. He worked with them for about 9 months. And then a private system came over from Wisconsin, took over the private work there, and recruited him. And I can't blame him. He's got loans to pay. So that's the situation there.
So with
It's
the
dire.
with the disinvestment that took place in the 90s and the early 2000s, as you kind of started with at the state level, that's truly, like in the UP, that's having a more drastic effect than maybe in the lower peninsula.
Correct.
Okay.
Correct.
I'd like to just shift gears real quick. You didn't talk about this, but I understand that North Care Network got to lead a pilot on the MyCal system.
I'm sorry, you were muffled. I didn't quite hear.
You led the pilot program for the MyCal system. Can you talk about that just briefly, and then we'll let you get back to your day.
Sure. I don't know too much about that. When I took over the directorship, the chief medical officer role, MyCal was already started. And so I came in and it was already in play. I know that we took that role over. I know we run that. But the problem again, and I've been involved in many situations, is that the lines, the phones, when they're answered, they're not answered necessarily by people who are there. And if they are answered by people in the UP, then they don't have the capacity to refer these patients out to where they need to go. That's what I hear from my staff. What they're called crisis or access staff, and that's their biggest problem is with the MyCal thing. Remember, think of MyCal as your emergency room or when you call 911. 911 is good. You can call 911, but if there is not a fire department and a police department and an emergency EMS service in your area, what good is that? So that's the hard stop for our MyCal folks answering those phones and providing those services. Before I forget, can I get 2 more minutes? I want to say something real quick. Dr. Anderson had mentioned good things that were happening in Michigan, and they are. I'm not negative, Nellie. And she mentioned something called the IMLC, Interstate Medical Licensure Compact, which basically is a compact amongst multiple states. Michigan was part of it. That licensure could be transferred. So if we had somebody licensed, a physician licensed, say in Ohio or Florida, they could come here and we would accept, and likewise from Michigan. Well, this morning I was reading in my news feed that Michigan is withdrawing out of IMLC. So that's a whole other. Then people have talked about PRTF or crisis stabilization units. The state actually has funded and has talked a lot about crisis stabilization unit. My opinion probably will be unpopular, perhaps in some areas, but I'm speaking on as the practicing physician. Think of crisis stabilization units as step down ICU, right? So having crisis stabilization units is great, but you need, for crisis stabilization unit to succeed, you need a higher level of care. So you need enough inpatient coverage for people to step down to it. And then you need, after the CSU, you need, I'm going to keep using that example, cardiology, somebody gets a heart attack, they go to the cardiac ICU, they step down to regular ICU, which would be your crisis stabilization unit. Then they go home and then they'll do rehab and then they'll go see their cardiologist and blah, blah, blah. In the same way, CSUs or crisis stab units are in between. They don't make up for lack of higher level of care. They function as a step down or step up, but without that step up in place, CSUs will not fix the problem. Because you know what other issue is? I know people, I've talked to people across the state medical directors who are working with crisis stabilization units, and they cannot find experienced psychiatrists to run that CSU because nobody in their right mind wants to take that on. How would you? If your CSU is not a step down and there is no step up, how am I going to treat for 72 hours? That's the maximum stay in a crisis stabilization unit. What's that going to do? Psych medications, my friends, take up to 4 to 6 weeks to work. The first 2 weeks, we just observe them because they might react, patients might react badly to them. It's a medical thing. So this CSU thing is great, but without having the step up hospital backup, this is not going to fix our problems.
I want to thank you for your testimony and your expertise today. We appreciate your time. I think every time we meet, and I think we're just about wrapped up with this conversation, there more becomes available, and we continue to find new avenues. So I do want to thank you. With that, and there being no further business before the committee will stand adjourned.